Welcome to everybody to the J. and Margie Grosfeld Research Symposium for APSA 2021. I'm one of your moderators. I'm Dr. Agostino Piero from the Hospital for Sick Children in Toronto, in Canada.
And I am Dr. Sean Kunisaki from the Johns Hopkins Children's Center and the Johns Hopkins University in Baltimore, Maryland.
Both Dr. Kunisaki and I are chairs of APSA Research Committee, and we are delighted to present 10 studies in this research session. But before starting, I would like to acknowledge Dr. Grosfeld and the fact that this is the J. and Margie Grosfeld scientific session. This will be dedicated on research on congenital diaphragmatic hernia, lung injury, and tumors, as you could see in the slide. Dr. Grosfeld was one of the giants of pediatric surgery. His name is well known to all pediatric surgeons. He was professor and director of pediatric surgery at Indiana University and Riley Children's Hospital since 1972, a post that he held until his retirement in 2003. In 1985, he was appointed chairman of the Department of Surgery, the first pediatric surgeon in the US to be so honored. He was an outstanding clinician and teacher, a master surgeon, and an innovative scientific investigator. He was the editor-in-chief of the Journal of Pediatric Surgery from 1994. He also initiated the very popular Seminars in Pediatric Surgery, and he was senior editor of the 2-volume textbook in pediatric surgery. For several generations of pediatric surgeons, including myself, Dr. Grosfeld was a mentor, a role model, and he helped to show the way in pediatric surgery. He was the chairman of the surgical section of the American Academy of Pediatrics, the president of the American Pediatric Surgical Association, APSA, in 2013. He was the first vice president of the American College of Surgeons. And during his career, he received many honors all over the world. Now, Dr. Grosfeld unfortunately passed away in 2016. And Dr. Grosfeld and Margie, which you could see here in the picture, his lovely wife, have been supporting APSA Foundation for many years. This year, research session is again dedicated to them. Thank you, Margie, and thank you to Dr. Grosfeld and APSA for this great honor of having this research session on your name. Let's go now to this session. This session includes APSA covering important research aspects of pediatric surgery. Each presentation will be followed by a short discussion from pediatric surgeons and scientific experts in the field. This year, the research session will be divided in 2 parts. The first part is dedicated to research and advances in congenital diaphragmatic hernia and lung injury. At the end of this session, Dr. Sean Kunisaki will provide a short talk summarizing the advances in this field of research. The second part will focus on various aspects of research in tumors, and Dr. Harold Lovern will give a short talk at the end, again focusing on the advances in research related to these tumors and also related to the presentation given. Thank you very much, and I hope you enjoy attending this research symposium.
Our first abstract in this session will be presented by Dr. Collage from the Hospital for Sick Children in Toronto. His presentation is entitled, Human Amniotic Fluid Stem Cell-Derived Extracellular Vesicles Restore Branching Morphogenesis in Epithelial Progenitor Cells in a Novel Model of Human Pulmonary Hypoplasia. Dr. Collage.
Thank you to the organizers for inviting us to present our work from Dr. Augusto Zani's lab. I'm a postdoc from SICKIs. It is well known that hypoplastic lungs of babies with pulmonary hypoplasia, secondary to CDH, have impaired fetal lung growth and maturation. Several treatment agents have been administered prenatally, but none have been successful in rescuing CDH lungs. Over the last 5 years, we have investigated the use of amniotic fluid stem cell-derived extracellular vesicles as a treatment for pulmonary hypoplasia secondary to CDH. We have demonstrated the therapeutic efficacy of rat-derived APSASEVs in vitro and in vivo rat, and more recently in vivo rabbit models of pulmonary hypoplasia, and also in vitro human alveolar epithelial cells. In search for a novel treatment, we have focused on extracellular vesicles that are nanoparticles secreted by any type of cell, including stem cells, and are known to have a great regenerative potential as they carry bioactive cargo in the form of genetic material, protein, and lipids. We have shown that administration of rat AFSCEVs restores fetal lung growth and maturation in a model of CDH, as we recently reported in Science Translational Medicine. Encouraged by these promising findings in fetal rats, we have now moved to the human. For this first of its kind project, we wanted to first establish the human explant model of pulmonary hypoplasia. To isolate AFSCEVs, we obtained amniotic fluid stem cells. We then collected their conditioned media, and using ultracentrifugation, we isolated the AFSCEVs. For our human explant model, we obtained fetal lung tissue from healthy terminations between gestational weeks 16 to 19, corresponding to the canalicular phase. We're particularly interested in this phase since it is the window of opportunity clinically where we can both diagnose and intervene on CDH fetuses. We cultured 1 to 2 millimeter specimens on nanopore membranes for 92 hours. Then, to induce pulmonary hypoplasia, we administered a RAC1 inhibitor, NSC23766, as it blocks FGF10 that is crucial for normal lung development. Interestingly, when we looked at autopsy specimens from CDH neonates, RAC1 expression was decreased, corroborating the importance of this pathway. So in this project, we had human explants that were either stressed or not stressed with NSC and treated or not treated with human AFSCEVs. Our primary outcome measures were branching morphogenesis, which we assessed using the mean linear intercept method as recommended by the American Thoracic Society to measure parenchyma to airspace ratio. We also looked at SOX9 expression as a marker of lung maturation. We first confirmed RAC1 inhibition by measuring RAC1 levels in these explants, and we observed a profound downregulation upon inhibitor administration. When we treated explants with RAC1 inhibitor, we recapitulated the impaired branching morphogenesis as evidenced by the increase in MLI compared to control. Please note that a high MLI value indicates pure airspaces. We then focused on lung maturation by looking at SOX9 immunolocalization and expression, and we found that hypoplastic lungs had lower SOX9 expression and distribution. We then went on to investigate whether human AFSCEV treatment could restore fetal lung growth and maturation. Remarkably, when we administered the human AFSCEVs, we saw a restoration of airspace density with decreased parenchyma. Likewise, human fetal explants treated with human AFSCEVs also had SOX9 expression and distribution rescued to levels close to those of control. In conclusion, we demonstrate efficacy of our human-derived AFSCEV treatment on two key aspects of pulmonary hypoplasia, growth and maturation. We are very excited as this is the first new avenue of our roadmap to translating this AFSCEV-based therapy to ultimately treat CDH in babies. Thank you to our funding sources, and thank you for listening.
Thank you, Dr. Collage. The invited discussant for this paper is Dr. James Dunn from Stanford University and the Lucille Packard Children's Hospital.
Well, that was a wonderful presentation, Dr. Collage. Amniotic fluid stem cells have been studied for over 20 years, and they have been used for a variety of things. And it's nice to see that the mechanism of action, at least for this particular application, appears to be through the extracellular vesicles. I wonder, have you tried using different doses of the extracellular vesicle as a therapy for this model?
So thank you very much for the question. So we have done dose optimization experiments looking into the best dose for the best effect. These studies were conducted with rat-derived AFSCEV that were administered to rat lungs, where we really were looking at narrowing it down to the number of EV particles in the dose. And so we performed dose down experiments by gradually decreasing the AFSCEV dose from 10% to 5%, and then the lowest dosage was 1%. And what we saw was that there's the beneficial effects essentially were diminished with the lowest dose. And so therefore from that study, we've now translated this dosing to the human EV administration and in particular to the human lung explants.
Very good. And I wonder if you have seen batch to batch variation with the preparation of the extracellular vesicles.
So that's a great question. Thank you. So our lab has experience with both rat as well as human AFSC cells. And with the rat AFSCs, we have a cell bank, and we continually check for this batch-to-batch variation. We have optimized our EV separation protocol, and we have consistently isolated EVs that are of typical size and contain the canonical markers that you would typically see specific to the EV markers. And so with that being said, as we think about the translational application now to humans, we require a stable source of these AFSC cells that are good manufacturing practice grade or GMP grade. And so we're now currently working with a company who has immortalized these cells, and they're now producing medical grade human AFSC EVs.
Very good. You've nicely shown that SOX9 expression is better preserved. Can you tell us what's the significance of that? And also, have you looked for other markers of maturation?
Yes, so thanks for that question. We have also conducted other maturation studies that are complementing what we saw with SOX9. We've looked at other markers such as surfactant protein C, and this is another great marker for fetal lung maturation in the canalicular stage in particular, especially as the alveolar epithelium is expanding and maturing at this stage in order to support the surfactant production.
That's great. My last question has to do with something that you probably need to speculate. What do you think is the active ingredient in the extracellular vesicles?
Yeah, so the EVs have various cargo. They carry a wide variety of different cargo in the form of genetic material, which includes various RNA species, as well as proteins. Now, our lab's previous work, which is currently in press at Science Translational Medicine, has teased apart some of the key cargo that is responsible for the promotion of the lung branching morphogenesis and maturation in our rat model of pulmonary hypoplasia. And so the proteomics analysis that was conducted on the EV cargo we ended up finding mostly proteins that were involved in RNA stabilization. And so when we looked at the RNA species in particular through RNA sequencing analysis, we found that most of the changes and the contributions of the beneficial effects that we were observing were from the microRNA in particular. And so we are specifically now interested in a specific family of microRNAs, the microRNA 1792 family, as well as their paralogs. And this family was one of the main top hits that was consistently appearing in our bioinformatics analysis. And it's of particular interest to us because it can regulate many of the common genes that are involved in fetal lung growth and maturation in pulmonary hypoplasia.
Well, again, thanks for your presentation. We look forward to this being used someday in clinical trials.
Great. Thank you very much for the stimulating discussion, Dr. Dunn.
I would like to invite now Dr. Stephen Nemec to present a paper on CMP microRNA to reduce the lung inflammation and fibrosis following acute injury.
Hi, thank you for taking the time to listen to our presentation on our work with CMP-MIR-146A in the treatment of acute lung injury. Here are relevant disclosures. Acute respiratory distress syndrome, or ARDS, can have an in-hospital mortality of up to 30% in the pediatric population, and patients who survive their initial hospitalization can often go on to develop reductions in pulmonary function. The acute injury seen in ARDS can be caused by a variety of etiologies, but regardless of cause, ARDS pathophysiology is characterized by excess inflammation and oxidative stress, which go on to result in pulmonary edema, hypoxic respiratory failure, and potential for fibrotic changes in the long term. A common inflammatory pathway in ARDS pathogenesis is the NF-kappa B pathway, which is a target of CMP-MIR-146A. CMP-MIR-146A is the conjugation of serum oxide nanoparticles, or CMP, to microRNA 146A. CMP is a divalent metal oxide that acts as a free radical scavenger, while microRNA 146A has anti-inflammatory properties by inhibiting IRAK1 and TRAF6, which are upstream promoters of NF-kappa B. We therefore hypothesize that intratracheal administration of CMP-146A could rescue the lung from this inflammatory process and thereby reduce inflammatory cell recruitment and collagen levels when looked at on histologic analysis. To evaluate this, we used a well-established bleomycin murine acute lung injury model. Bleomycin is a toxic chemical that produces an acute inflammatory action and then leads to sustained fibrosis over the course of 2 to 3 weeks. Age-matched mice were injured with intratracheal bleomycin or an equivalent volume of saline as controls. 3 days following this injury, a subset of bleomycin-injured mice were given intratracheal treatment with CMP-146A, while the remaining mice received saline. 14 days following the initial injury, lung tissue was harvested and processed for histologic analysis. Slides were stained with either CD45 or trichrome. CD45 is a common leukocyte antigen and therefore stains all white blood cells brown when looked at under the microscope, while trichrome staining stains collagen fibers blue and is used to look at fibrosis. For each sample, 20 random high-powered fields were imaged and quantified using NIS image-guided software. CD45 cells slides were quantified for positive cells per high-powered field, while trichrome stain slides were quantified for area of collagen per high-powered field. We found that 14 days following initial injury, leukocyte infiltration on histologic analysis was significantly higher after bleomycin injury, and that treatment with CMP-146A lowered this to controlled levels. This correlated with changes in collagen deposition as well, in which control and CMP-146A treated mice had significantly lower collagen levels per high-powered field compared to bleo-injured mice. In conclusion, IT treatment with CMP-146A 3 days after lung injury could reduce inflammatory cell infiltrate and collagen deposition within the lung, and this could lead to significant implications for ARDS treatment in the future. Thank you, and I'm happy to take any questions if you have any.
It is a real pleasure to discuss this paper from Dr. Nemec, and I would like to congratulate Stephen and his supervisor, Dr. Licci, and all the collaborators. Acute respiratory distress syndrome, or ARDS, is an important, very challenging clinical problem in pediatrics and in pediatric surgery indeed. ARDS can lead to pulmonary fibrosis and respiratory dysfunction. The hospital mortality for this very morbid disease remains high and is calculated approximately around 40%. The clinical problem is not just related to adults, but also to children. That's why it's also important in pediatric surgery. Indeed, the coronavirus pandemic increases the incidence and possibly the severity of ARDS, making the discoveries of Dr. Nemec more important and very timely. The current management of lung injury and ARDS is limited to supportive care with mechanical ventilation, and this highlights the need for developing a novel therapy. Intratracheal drug delivery systems offer a very good theoretical benefit with therapy that could be directed to trachea and possibly also to the entire lung. Intratracheal delivery has been effective in many conditions, including congenital diaphragmatic hernia or gene delivery for endobronchial cancer. This delivery model could potentially overcome natural barriers in the lung, such as surfactant, respiratory epithelium with ciliated epithelium. The authors of this paper and evaluated the role of intratracheal therapy in an experimental model of lung injury based on bleomycin. They explored the role of nanotechnology as a vector, and indeed, this nanotechnology is a rapidly expanding field with several potential clinical applications. Now, there are two main components in the novel therapeutic approach of Dr. Nemec. The first one is related to the use of cerium oxide nanoparticles, or CMP. The second one is related to microRNA, in this case, microRNA 146A. So the first one, CMP, has been utilized because it has oxygen scavenging potentials, and so could reduce the oxidative state. Indeed, recent review has highlighted that the potential of CMP could be important in treating acute lung injury and also ARDS during coronavirus. CMP can act by affecting NF-kappa B and the inflammatory cascade that is regulated by that. This pathway is known to be at the base of acute lung injury, but also ARDS. The second component is microRNA, in this case, microRNA 146A, and microRNA can affect similarly inflammation and also this pathway of NF-kappa B. The advantage of using both compounds together seems to be related to the stability of microRNA, which could be unstable and therefore joined with nanoparticles can offset the negative charge of microRNA and enhance the stability. The study that you just heard is highly innovative and very rigorously done. They utilize a new methodology, and I would like to ask some questions that will give to Dr. Nemec also the possibility to say a little bit more about his excellent research work. The first question, can you please expand on what do you think is the underlying mechanism of action of nanoparticles and mRNA? Particularly, does this combination affect the periphery of the lung when it's administered intratracheally?
Yeah, Dr. Vieira, thanks for the questions and for the summary. As you mentioned, we think that CMP and microRNA 146A are going to act synergistically. And with CMP, because it's a divalent cation, should act as a reactive oxygen scavenger. And then microRNA 146A, we've shown in vitro, is able to directly inhibit TRAF6 and IRAK1, which are upstream of NF-kappa B, which, as you mentioned, is an important contributor to acute lung injury and the inflammation we see. With regards to the exact location within the lung that these are going to be working, we're still working on finalizing or studying that. So the acute lung injury that we see with bleomycin and that patients develop with ARDS is heterogeneous throughout the lung. And so there's often patchy areas. We haven't yet studied the specific location that CMP-146A is going to be acting when we give it intratracheally, although it does appear to stay local within the lung, which we think is beneficial.
Fantastic. Well, thank you much. Then my second question is this compound, this joint compound, has been used also topically, as you know, in diabetic wound healing, impairment of the healing of the wound. Now, for translational purposes, are there any side effects by giving this compound intratracheally that you know?
Yeah, that's an important question when we're thinking about translating this. So our initial studies with CMP-146A were in diabetic wounds. And so because we saw that reduction in inflammation and oxidative stress, we wanted to translate, see if that would work in acute lung injury, which has that in its pathogenesis. When we've given CMP-146A intratracheally, we haven't seen any systemic spread. So we've looked in the plasma, spleen, liver, heart, and kidney, and using ICP-MS or inductively coupled plasma mass spectroscopy, and then PCR for the microRNA. We haven't seen any increase in those systemic areas with that delivery. So we think that it's a more local effect, which should hopefully reduce risks, although we don't know the specific problems within the lung that it could be causing. One of the challenges with any anti-inflammatory therapy is that some inflammation is important for healing. We need that. MicroRNA 146A is part of an intrinsic pathway in down-regulating inflammation. So we're sort of taking advantage of that already intrinsic pathway. So we're hoping that those risks are reduced. But looking in a more clinical setting will be important to make sure that we're not overcompensating in that anti-inflammatory pathway.
Fantastic. Thank you very much. Now, my other question is that something related to the age of the individual, because we are pediatric surgeons. So do you think that the development of the lung, which continues in the first few years of life, may have an influence in the response to CMP microRNA, or because your model is obviously based on adult mice?
Yeah, I think that that's a really important question that we haven't yet investigated. With acute lung injury clinically, patients have such a wide range in inflammatory responses and the development of ARDS. Their injury pattern is fairly heterogeneous. And so investigating various ages, varying degrees of inflammation that's produced will be important when we're working on translating this therapy, and it'll require some additional studies to be able to evaluate or age, sort of the age range that this would be most beneficial at.
Very good, Steve. I have a final questions, and you may have some data on that. I mean, ultimately, what is important is the function of the lung. Do you have any data, which obviously you couldn't present here because limited time, on pulmonary function after this treatment?
Yeah, that's a great question, and thanks for bringing that up. That's really like the main question in the translational research is how does it affect the end goal, which would be function, and we have seen that intratracheal treatment with CMP-146A is able to improve pulmonary function. We've tested this in both a bleomycin model, like we presented here, as well as a LPS or lipopolysaccharide induced injury model. And in both of these models, we were able to see improvements in pulmonary compliance, inspiratory capacity, and pulmonary elastance in our murine model. And so here we've sort of shown that we have improvements in the leukocyte recruitment as well as in the collagen deposition long-term, but clinically, at least from our murine model, that's translated to reductions in or improvements in pulmonary function.
Fantastic. I think I would like to congratulate you, congratulate your supervisor, and all the collaborators for this superb research. In my opinion, your findings have an important translational potential, and I'm sure continuing like this, you could generate great clinical impact. Well done.
Thanks, Dr. Pierre. I appreciate the questions and the time offered to present this work.
It's been a pleasure to discuss your paper. Thanks.
Our next abstract in this session will be presented by Ms. Antunians from the Hospital for Sick Children in Toronto. Her presentation is entitled, "What's Wrong with Hypoplastic Lungs of Fetuses with Congenital Diaphragmatic Hernia? Transcriptomic Profiling of the Pulmonary Epithelium from Fetal Hypoplastic Lungs." Ms. Antunians.
Hello, I'm from Dr. Augusto Zani's lab at Sick Kids in Toronto. Thank you to APSA for giving us this opportunity. Pulmonary hypoplasia secondary to congenital diaphragmatic hernia is a severe condition characterized by underdevelopment of fetal lungs. Hypoplastic lungs are small, have fewer branches, and their epithelium is less proliferative and immature. The mortality and morbidity of these babies is directly related to the degree of pulmonary hypoplasia. We know intervening after birth is too late. Hence, there have been many attempts to promote fetal lung growth and maturation prenatally. The most common and reliable experimental method to model CDH is based on the nitrogen administration to pregnant rats, which causes pulmonary hypoplasia in 100% of the litter. More than 500 papers have been published using this model, and we and others have shown that fetal lungs exposed to nitrophin have fewer terminal buds, reduced lung surface area, immaturity with lower surfactant expression, and decreased number of vessels and thicker medial walls. Some of the attempts to prenatally treat pulmonary hypoplasia have shown great promise in these animal models, like the administration of vitamin A and surfactant, but none are currently used in clinical practice. Most recently, 3 clinical trials testing antenatal sildenafil administration were halted after multiple fetuses died. We think that many of the pharmacological attempts, nicely listed here in a table from Dr. McKinsey's group, failed to achieve lung growth and maturation as they were addressing one single factor or pathway. As CDH pathogenesis is multifactorial, our aim was to comprehensively characterize the dysregulated factors and pathways in epithelial cells derived from this model. After nitrophin administration on embryonic day 9.5, dams were sacrificed at E14.5 and fetal lungs were trypsinized to form a single cell suspension. Following serial fibroblast depletion steps according to an established protocol, we grew lung epithelial cells. Our control group was derived from normal fetal lungs from mothers that had not received nitrophin. We validated that these cells express surfactant and when grown in matrigel formed surfactant-expressing organoids. Lastly, we analyzed the proliferation and cell death rate to confirm disruption in cellular homeostasis. We performed RNA sequencing on 6 biological replicates from each condition and compared gene expression changes and performed pathway enrichment analysis. Our principal component analysis nicely separated the data based on condition, and on differential analysis, we found 661 downregulated and 322 upregulated genes. With gene set enrichment analysis, we found the following pathways that were downregulated by nitrophin exposure, including the collagen degradation pathway with extracellular matrix deposition genes like collagen in matrix metalloproteinases that are critical for airway development. Another pathway is interleukin signaling, which is regulated by PI3K, AKT, RAS, and RAP pathways. Together, they control response to external stimulus and act as molecular switches for proliferation, survival, and growth. When we looked at the pathways that were upregulated by nitrophin, some of the interesting hits included caterins that regulate epithelial cell polarity and regulate tight junction proteins, and changes to retinoic acid signaling with an increase in catabolic enzymes and SUMO family members that regulate retinoic acid shuttling. Ultimately, these pathways cause changes in branching morphogenesis through FGF10 signaling and vascularization through VEGF signaling, and have consequences on cell proliferation and surfactant metabolism. In conclusion, the RNA sequencing profile of epithelial cells from lungs of fetuses with CDH is a resource that can be used to identify major transcriptional changes. This study links together for the first time the dysregulated factors and pathways in the epithelium that contribute to pulmonary hypoplasia secondary to CDH. The implication of the study is that to effectively promote fetal lung growth and maturation, the ideal therapy for babies with CDH should be multi-targeted and address all dysregulated biological pathways. I'd like to thank the rest of the Zani Lab and our funding sources who've made this all possible. Thank you very much.
Thank you, Ms. Antonians. The invited discussant for this paper is Dr. Ann Fisher from Palm Beach Children's Hospital.
Excellent work from the Dr. Zani lab on creating a gene signature. Given the broad impact of nitrogen exposure on the dysregulation of the 983 genes in this pathway, were you able to, one, either identify a key precursor gene to correct in utero via the sexy CRISPR, or two, identify a key gene signature to correlate severity of CDH prenatal diagnosis long before ultrasound findings?
So thank you for the question. One of the main phenotypes that we observe in human CDH that is mirrored pretty consistently in the nitrophin model is the impairment in branching morphogenesis. Now, the underlying reason to this is because there is epithelial immaturity. So when we look at one precursor gene or pathway that is the master regulator of this, it's the FGF10 pathway. And actually, when we inhibit FGF10 in our human lung tissue samples, we end up reestablishing what we see in the nitrophin model, which is impaired branching. So this dysregulation in FGF10 might actually then lead to all the downstream genes that are implicated. And of course, we've identified a number of genes and not just one. So one way we can better understand how these genes are regulated together is to look at their master regulators. And these would be non-coding RNAs that work like dimmer switches that can either ramp up or ramp down the variety of targets that we see in our study. So what's really fascinating about this is they can act both as targets and as biomarkers. So this answers both of those questions because the idea of being able to prenatally diagnose using these signatures is exciting. And actually, it's already been shown by a couple of researchers that have looked at severity of CDH, need for ECMO, and outcomes of fetal. So just by using these regulators of the gene.
Thank you. Second question, how would you translate your findings into a potential therapy to be administered to the human corollary of CDH?
So this touches on a field that we've been working, we and others have been working very hard on, which is the fetal regenerative medicine field. So we know that intervening after birth is too late and that the fetus would benefit from a multi-targeted therapy in utero. So over the last 5 years, we've been using extracellular vesicles derived from amniotic fluid stem cells. And we've been able to promote lung growth and maturation in multiple models of pulmonary hypoplasia. And we found that these vesicles contain the microRNAs that are the dimmer switches of these genes. So one way we can apply this in utero is to utilize a combination of these microRNAs to target the pathways that we identified in the study here. And thinking translationally into the clinic, we've been obtaining good manufacturer practice grade human amniotic fluid extracellular vesicles, and they've shown great promise in ex vivo models of human pulmonary hypoplasia. And we know that these vesicles contain those microRNA, those regulators. So in the future, we could potentially administer these vesicles in utero to the mother multiple times and hope to reach the fetal tissues and promote maturation.
Great. Considering that nitrophen induces 54% incidence or variable of the CDH defect, do you all have data to show the effect of the nitrophen exposure itself that did not result in a diaphragmatic defect? So in a way to sort of have an extra control experimentally to subtract out the gene expression from the nitrophen alone.
That's a great suggestion. So the time point that we've looked at in this particular study is E14, and diaphragm closure occurs at E18. So stemming from this project, what we've been doing is looking at lungs at E18, either with a defect or without a defect. And we're performing single cell RNA sequencing to understand not only what happens to the epithelium, but also the other cell types that are important, like the endothelium and other components of the mesenchyme. So this way, as you suggest, we can subtract out the nitrophen effect and look simply at what the diaphragmatic defect is doing to the lung development.
Thank you so much. Excellent work.
I would like to ask Dr. Vikas Gupta to present the paper on congenital diaphragmatic hernia, associated pulmonary hypoplasia, and inflammation are initiated in utero.
Thank you for the opportunity to present our work. It is a privilege to be part of the J and Margie Grosfeld Symposium along with the other excellent scientists. We have no disclosures. One of the challenges of managing patients with congenital diaphragmatic hernia is hypoxia. These patients are profoundly hypoxic and they require high levels of respiratory support. They often require extracorporeal life support. This hypoxia stems from three main factors: pulmonary dysfunction, pulmonary hypoplasia, and pulmonary hypertension. The hypoxia-inducible factors, also known as HIFs, are transcription factors that in the presence of normoxia are degraded by our cells. But in the presence of hypoxia, HIF proteins cross-link and become stabilized. Previous work from our lab has established that in the immediate postnatal period, lungs from rodents with CDH are nearly 25 times more hypoxic than the lungs of control rodents. Moreover, we were able to establish significant increases in HIF1 alpha and HIF2 alpha expression in CDH rodents compared to controls. There is a known link between hypoxia and inflammation that has been established in a number of oncologic, pulmonary, and infectious models. Our team has established that postnatally, CDH rodents express higher levels of inflammatory proteins compared to controls. Little is known, however, about CDH pulmonary changes in the prenatal period. We hypothesized that CDH-associated pulmonary hypoxia and inflammation are initiated in utero. We used the standard Sprague-Dawley rodent model of CDH. This is a well-established model in which nitrophen, a teratogenic compound that acts on the retinoic acid pathway, is given to pregnant dams at gestational day 9.5. On gestational day 21, 1 day before the normal gestational period of 22 days, dams are placed in 3 groups: controls on room air, controls in 8% hypoxia, and nitrophen-exposed dams on room air. Each group is then injected with intraperitoneal hypoxyprobe. Hypoxyprobe is a pimonidazole hydrochloric acid and is a marker of tissue hypoxia. 1 hour later, dams undergo laparotomy and pups are delivered. Pups from each group undergo immediate tissue harvest. Left lung tissue is taken for immunofluorescent staining and confocal microscopy or Western blotting. Hypoxia probe measures tissue hypoxia and stains pink on confocal microscopy. As you can see, there is some hypoxia staining in the lungs of control room air pups. There is slightly more hypoxia probe in the 8% hypoxic controls. And finally, in CDH pups, there is a significant increase in the degree of hypoxia staining. Our quantification data shows a nearly 3-fold increase in hypoxia in prenatal CDH lungs compared to prenatal control lungs. Despite the increase in tissue hypoxia, HIF1 alpha expression was similar between the prenatal and control CDH lungs. The same went for HIF2 alpha, which also had very similar expression between groups. Inflammation, measured by tissue levels of C-reactive protein, however, was significantly higher in the prenatal CDH lungs compared to prenatal control lungs. In conclusion, CDH lungs are more hypoxic and have higher levels of inflammation than controls. Despite the tissue hypoxia, hypoxia-inducible factors are not upregulated in CDH lungs prenatally as they are in the immediate postnatal period. These data have prompted us to evaluate the role of hypoxia in other aspects of CDH pathophysiology. For example, hypoxia may play a role in CDH-associated cardiac dysfunction. Preliminary data from our lab has suggested that both the right and left ventricles of CDH rodents are profoundly more hypoxic compared to controls. This could potentially lead to decreased mitochondrial yield and altered mitochondrial structure. Moreover, our lab is working on further understanding the mechanisms of these pathways by using dimethyloxylaglycine, or DMOG, a stimulator of HIF expression. Our investigation is focused on understanding whether increased HIF expression will help CDH rodents adapt to hypoxia, or will it make inflammation worse. We are also working on translational studies using Nuvox, a nanoparticle that increases tissue oxygen carrying capacity. Thank you for the opportunity to participate. I'm now open for any questions.
Thank you, Dr. Gupta. The discussant for this paper is Dr. Sam Soffer.
All right, Dr. Gupta, that was a wonderful presentation of some excellent scientific work. I recently had the pleasure of hearing Dr. Harding, your mentor, give a virtual presentation regarding clinical aspects of congenital diaphragmatic hernia, and it is so encouraging to see such a nice basic science element added to your group's expertise in this challenging problem. I have 2 questions for you. I'll start with the first one. From reviewing your data, differences in inflammatory markers of protein expression are quite striking, but not in the hypoxia markers. The hydroxyprobe staining is interesting, but it may not necessarily be quantifiable. Is it possible that there is an increased inflammatory process at play, not necessarily associated with hypoxia?
Thank you for the excellent question, Dr. Soffer, and for the kind comments. It's clear that, as you said, in the prenatal period, the HIF proteins seem to have similar expression in both control and CDH lungs. With our hypoxia probe data, we do still think there is hypoxia-related inflammation that plays a role in CDH prenatally and certainly postnatally. I think we've all seen CDH patients in the postnatal period that are hypoxic. Our lab has done some postnatal work showing increased inflammation, et cetera. Despite that, it is definitely possible that other inflammatory pathways are involved. Obviously, it's unlikely to be an infectious or autoimmune component to the inflammation, but there certainly could be a traumatic component in terms of inflammation related to mechanical compression of the lung by the abdominal organs that are now in the chest. Moreover, we know that pregnancy itself is a pro-inflammatory state, so the increased inflammatory markers could also be related to maternal physiology. And what we're doing in our lab to actively investigate this is we're looking at multiple different inflammatory markers. In this presentation, we had CRP data available, but we're looking at other things such as IL-6, TNF-alpha, et cetera, to further understand this question.
Right. I saw your future directions in the lab on the last slide or 2. How does this potentially translate clinically? Is an anti-inflammatory strategy as a potential modulator of in utero lung development for CDH, as is commonly used today for CCAMs, a viable strategy?
The question about clinical translation is always important. And so about the CCAM and those kinds of strategies, while both clinical trial and registry studies of prenatal steroids for CDH patients showed no benefit in terms of morbidity or mortality, it could actually be time to revisit those and other anti-inflammatory strategies in CDH. Our lab has previously published that the use of extracellular vesicles can decrease inflammatory markers in the postnatal version of this model, and we are investigating the effects of prenatal administration of extracellular vesicles as well. We are also approaching this question about treatment from a slightly different angle. Remember, we believe that the inflammation is an endpoint of the hypoxia. So we are studying ways to both, one, increase the tissue oxygen delivery, so just decrease hypoxia globally for the CDH pups in utero. And second, we're seeing if we can modulate HIF expression. In hypoxic conditions, the HIF proteins have some positive adaptive effects, such as increasing tissue vascularity and augmenting cellular metabolism. So it's possible that CDH rodents could benefit from increased HIF expression. So in our study, we showed that the HIF expression was similar between control and CDH prenatally. Maybe the CDH pups need more HIF to respond to hypoxia and decrease that inflammation. There are some compounds that we're investigating that can alter HIF expression prenatally, such as DMOG and roxadustat. Hopefully that answers your questions.
No, definitely. It's challenging sometimes, particularly it's one thing to try and block blood vessels, which I have a lot of experience with.
Mm-hmm.
But when you try and actually increase blood vessels, it can actually get very, very challenging. But I admire your work. I think it's wonderful. I think it's the future. And God knows we need everything we can get in diaphragmatic hernia. So thank you for your presentation.
Thank you for moderating. I appreciate it.
Look forward to meeting you in person.
Our next abstract in this session will be presented by Dr. Yu from Boston Children's Hospital and Harvard Medical School. Her presentation is entitled Heparin and Enoxaparin Impair Pulmonary Function After Murine Left Pneumonectomy. Dr. Yu.
Thank you for the opportunity to present our work. We have no disclosures. Neonates with congenital diaphragmatic hernia, or CDH, often suffer from pulmonary hypoplasia, which is characterized by small and underdeveloped lungs with decreased alveolarization. The most critically ill of these patients may require extracorporeal membrane oxygenation, or ECMO, and systemic anticoagulation, most often with heparin. Expeditious pulmonary growth while on ECMO is imperative to reduce mortality, which approaches 50%. Using murine left pneumonectomy-induced compensatory lung growth as a model of pulmonary hypoplasia, our group previously demonstrated that anticoagulation with unfractionated heparin resulted in decreased alveolarization, which was correlated with decreased lung volume and significant decreases in parenchymal volume, alveolar volume, and septal surface area, the functional area available for gas exchange. In addition to critically ill CDH patients requiring ECMO and therapeutic anticoagulation, a much larger population of patients received subtherapeutic anticoagulation with lower doses of unfractionated heparin or are anticoagulated with low molecular weight heparin to maintain patency of venous catheters or treat or prevent venous thrombosis. These patients may also have concomitant pulmonary pathology. We now investigate the effects of subtherapeutic unfractionated heparin and therapeutic low molecular weight heparin on post-pneumonectomy pulmonary functional outcomes. 8-week-old male C57 Black 6 mice that did not undergo surgery were treated with low-dose unfractionated heparin, high-dose unfractionated heparin, or low molecular weight heparin or enoxaparin. Volume-matched saline was used as a control. Plasma PTT and antifactor 10A levels were measured to determine the degree of anticoagulation achieved. High-dose unfractionated heparin significantly increased plasma PTT. Both high-dose unfractionated heparin and low molecular weight heparin significantly increased antifactor 10A levels, while low-dose unfractionated heparin did not. A separate cohort of mice underwent treadmill exercise tolerance testing at baseline 2 days prior to left pneumonectomy and on postoperative days 4 and 8. They were subject to systemic anticoagulation during the postoperative period. At baseline, while the majority of mice had comparable exercise tolerance, mice randomized to receive high-dose unfractionated heparin ran for longer distance and time compared to their counterparts preoperatively. This may be due to intrinsic differences in physiology or behavior in these individual mice. On post-op day 4, after left pneumonectomy, mice that were anticoagulated had decreased running distance and time compared to their respective controls, although this effect did not reach statistical significance. However, in order to account for behavioral and intrinsic physiologic differences between mice, time spent running and distance run were compared in each mouse pre and post-intervention and reported as a % change compared to baseline values. When accounting for differences in baseline, a significant impairment of exercise tolerance becomes apparent in both subtherapeutic low-dose and therapeutic high-dose heparin-treated mice compared to saline control-treated animals on post-op day 4. Continued anticoagulation until postoperative day 8 significantly reduced exercise distance, and time in both the low-dose unfractionated heparin and low molecular weight heparin-treated cohorts. When accounting for differences in baseline, a significant impairment in exercise tolerance was revealed in all 3 anticoagulated cohorts compared to their respective saline controls by post-op day 8. It is important to consider the clinical implications of our data. Neonates with CDH require therapies to accelerate lung growth to overcome their pulmonary hypoplasia, and our historical data have indicated that heparin impairs lung growth and development. Our results presented today demonstrate that therapeutic unfractionated heparin and subtherapeutic unfractionated heparin, as well as Lovenox, all impair murine post-pneumonectomy exercise tolerance. These data suggest that heparin and enoxaparin, including at subtherapeutic dosing, may worsen functional outcomes for neonates with CDH and pulmonary hypoplasia. Accordingly, the choice of drug, dose, and duration of anticoagulation for neonates with hypoplastic lung disease should be reconsidered. Thank you, and if there are questions or points of discussion, our contact information is provided here.
Thank you, Dr. Yu. The invited discussant for this paper is Dr. Scott Short from the University of Utah and Primary Children's Hospital.
Hi, Scott Short from Salt Lake City Primary Children's. I want to congratulate Dr. Yu and colleagues on their study evaluating heparin and its impact on pulmonary development in models of pulmonary hypoplasia. Dr. Yu, in your model, you observed significantly shorter exercise tolerance in your baseline controls when comparing your intraperitoneal to subcutaneous administration. Are there elements of abdominal discomfort limiting the activities of your mice? This appears to be an area that may limit your findings.
Sure. Thank you, Dr. Short, for the question. All mice get pain control per animal care instructions at our institution with extended release buprenorphine after surgery every 48 hours for 72 hours. So while it's possible that an abdominal stick is more painful than a subcutaneous stick, the baseline exercise tolerance is performed before any surgery or injections. So it's difficult to identify the exact reasons for different baselines in exercise tolerance, but it's likely more important to just compare each mouse to itself at baseline and then at post-op, as this minimizes the confounding factors of slightly different conditions on different testing days and intrinsic differences in exercise tolerance between cages or individual mice.
Excellent. And have you considered other methods besides exercise to evaluate their pulmonary function, such as PFTs?
Yes, we have. As you can see, the exercise tolerance is probably more variable and subjective than some of these other measures. And so we have looked at PFTs, although not presented in this abstract. We perform mouse PFTs using a flex event system, which can measure pulmonary mechanics as well as volumes. So very briefly, we do observe a decrease in total lung capacity as well as inspiratory capacity in mice that are anticoagulated with either low or high dose unfractionated heparin, as well as low molecular weight heparin compared to their respective controls. And on another note, there's also a decrease in lung volume as measured by water displacement in anticoagulated mice. And this measurement includes the volume of the pulmonary parenchyma in addition to the total lung capacity measured on PFTs.
And have you guys looked at the possible underlying mechanism of action? I think one would be worried that the shared pathway that heparin may utilize with other options for anticoagulation would prevent barriers. Are there other options out there, and what are next future steps you might see?
Sure, thank you for this insightful question. Mechanism is obviously always in the back of our mind, especially when thinking about how to treat our patients. Our previously published work provided some preliminary data that bivalirudin, which is a direct thrombin inhibitor, did not have the same detrimental effects as unfractionated heparin with respect to lung volume by water displacement or total lung capacity on PFTs. And as we know, unfractionated heparin affects both thrombin as well as factor 10A, while the low molecular weight heparin, enoxaparin or Lovenox, as used in this study, should affect only factor 10A and have minimal effects on thrombin. So as such, the ongoing work in our lab uses the same compensatory lung growth model to evaluate the molecular, histological, and functional outcomes when anticoagulating with 2 direct thrombin inhibitors, both bivalirudin, expanding on our original data, as well as argatroban, and also looks at fondaparinux, which is a low molecular weight heparin-like anticoagulant that targets only factor 10A. And so hopefully this will provide some insight into whether the detrimental effects of heparin are dependent on the anticoagulation pathway versus other molecular interactions, and will hopefully also help identify if there's a more appropriate anticoagulant that should be used in patients with pulmonary pathology.
Thank you, and congratulations on your work.
Thank you.
I'm extremely pleased now at the end of this excellent session on diaphragmatic hernia and lung problems to introduce Professor Sean Kunisaki from Johns Hopkins in Baltimore, which has a long-lasting experience of research in this field, and is also vice chairman of the research committee and chairing this session with me. He will give you a short talk on the research advancement in this field with reference, obviously, to the papers presented. Sean, please.
Thank you and good afternoon, APSA members and guests. During this segment of the Jay and Margie Grosfeld Symposium, my goal is to contextualize some of the CDH lung abstracts that you've just heard by providing an overview of current, basic and translational scientific research efforts that are happening more broadly in the field. But before I get started, I'd like to give a special thank you to the APSA Research Committee Chair, Dr. Agostino Piero, for giving me the opportunity to present on one of my favorite topics in pediatric surgery. I have no disclosures. The roadmap for my talk is as follows. First, I will highlight the significance of CDH and why we as pediatric surgeons care so much about this disease from a basic and translational science perspective. Then I will briefly talk about prenatal surgery, mainly fetal tracheal occlusion, or FETO, before moving on to CDH disease pathogenesis and the two major categories of non-surgical experimental fetal therapies, namely drugs and stem cells. So with 4 CDH abstracts featured in this APSASode, there are several good reasons why basic and translational scientific research remains so vibrant within our APSA membership. First, it is a disease that is highly specific to pediatric surgeons. Really no other field in medicine truly understands and cares for CDH as much as we do. Second, the disease is highly prevalent, affecting about 1,200 children in the US each year. Third, the unadjusted mortality rate remains quite high nationally, on the order of 30%. And studies have shown that these rates have really not changed much over the past 3 decades. And that's despite ongoing refinements in surgical technique, programmatic efforts aimed at standardization and quality improvement, over 30 years now of experience with ECMO and the use of anti-pulmonary hypertensive medications, and novel ventilator strategies, among other interventions that have now come and gone along the way. Fourth, we have come to appreciate that among long-term survivors of CDH, there continues to be substantial morbidity in the form of chronic lung disease and other sequelae in this patient population. And finally, studies have shown that the median cost to the healthcare system to manage one CDH child is now in the hundreds and thousands of dollars, making CDH easily the most expensive non-cardiac surgical anomaly managed in our NICUs. As surgeons, perhaps the most intuitive approach would be to simply continue our relentless pursuit of a fetal operation to fix CDH and reverse the natural history of aberrant lung development. Of course, Dr. Mike Harrison and other fetal surgeons started this approach in the 1980s with open fetal surgical repair before transitioning for a variety of reasons to fetal tracheal occlusion, otherwise known as FETO, both in Europe and in North America. Unfortunately, Mike Harrison's trial, which was published in the New England Journal of Medicine in 2003, really failed to show benefit in terms of improving neonatal outcomes when compared to the control group. Although the procedure and patient selection have certainly been refined, and the final results from the European-based total trial are still forthcoming, ultimately, technical challenges will always remain, not everyone that will benefit from FeTO is a candidate, and its effects on the pulmonary vascular component are still a bit unclear. And as someone who works at a fairly busy FeTO center myself, I do not think that FeTO will be a big game changer in most cases of CDH. More to come on this from the APSA Fetal Committee APSASode in September. The bottom line is that we desperately need to still think outside the box. The accepted CDH abstracts for this APSASode are really exciting because they all take a deeper dive into our roots as basic and translational surgeon scientists who study the cellular and molecular biology of lung development to affect change in our patients with CDH lung hypoplasia. If you haven't already, I would encourage you to read this very powerful editorial on the scarcity of surgeon scientists that was published in Nature in 2017. An excerpt from this paper is shown here on this slide, stating, "The flow of surgeons out of research is a problem that must be recognized and stopped. Translational medicine needs them too much. They are much needed for crucial research into surgically treated diseases that only rarely hit the headlines, particularly the correction of congenital birth defects." And it goes on. And as the new secretary of the APSA Foundation under the leadership of Dr. Mary Fallett, I would also like to encourage the entire APSA membership to donate to help support our early career surgeon scientists who are trying to establish themselves as independent investigators in surgical science. In 2021, we've now come to appreciate that the complex disease pathogenesis of CDH simply cannot be explained by extrinsic mechanical compression from the herniated abdominal organs. Sure, the hernia is important and contributes to the disease process, but there's also mounting evidence, including work from my lab in our recent publication on lung organoids, that intrinsic lung developmental abnormalities are independent from mechanical compression, and these are likely present in most CDH patients. Unfortunately, despite important work by some of the true giants in surgery in our field, such as Pat Donahoe and others, the genetic origins of these intrinsic lung defects have remained elusive, with over 65 CDH-causing candidate genes being described in the literature. Although uncovering the genetic underpinnings of CDH remains an important endeavor, most investigators have therefore concluded that CDH is a polygenetic disorder that is caused by a heterogeneous and sporadically occurring group of gene defects. The common link, of course, amongst these patients is that they lead to similar downstream effects on the lung during the canalicular stage of development. So ultimately what we have are impairments of alveolar growth within the epithelial compartment in conjunction with abnormal pulmonary vascularization and smooth muscle development within the mesenchymal compartment. One major experimental approach to affect fetal CDH lung growth is the use of pharmacologic agents. This approach would include drugs such as steroids and vitamin A. Steroids have been shown in experimental models to work via the TTF1 transcription factor to affect lung branching, morphogenesis, and maturation, and may enhance pulmonary vascular development, potentially secondary to its anti-inflammatory effects. Dr. Kevin Lally from UT Houston led a small randomized trial in 2006 that unfortunately failed to show benefit of maternal steroid administration, but interest remains in the drug, perhaps in conjunction with other therapies. Vitamin A has also been of interest as a potential treatment for CDH, given that retinoic acid, a metabolite of vitamin A, is thought to be dysregulated during CDH lung development. Although vitamin A administration has shown benefit in the nitrophin rat model of CDH, there's really limited data in humans that it works, and experience suggests that vitamin A may actually be teratogenic. A fairly hot topic in CDH research right now and over the past decade has been sildenafil, a phosphodiesterase type 5 inhibitor that works by increasing cyclic GMP and facilitating nitric oxide mediated vasodilation. Both intraamniotic and maternal sildenafil have been shown to improve pulmonary vascular modeling and may secondarily have effects on lung alveolar growth in rodent models. We are eagerly awaiting data, however, from human trials on prenatal sildenafil, which are ongoing. In the abstract that was eloquently delivered by Ms. Antunians from the Augusto Zani Laboratory from Sick Kids in Toronto, an established nitrophin rat fetal lung explant model of CDH was used to isolate lung epithelial cells. She then explored different molecular pathways using RNA-seq, a next-generation gene sequencing technique that allows one to quantify the cellular transcriptome of these hypoplastic lung epithelial cells at a specific moment in development. This analysis revealed multiple and potentially novel transcription differences that are specific to CDH, including the downregulation of collagens, IL-4, and IL-13 with increased retinoic acid expression. Therefore, this body of work adds to the growing number of molecular biology studies aimed at understanding how to best modulate CDH lung development. These pathways could then be upregulated or downregulated using a variety of techniques, including gene therapy approaches, to improve fetal lung growth and pulmonary blood vessel development. In similar vein, other pediatric surgery laboratories, including the Kaiser Group from Winnipeg, have been looking at microRNAs and how some of these may be important in the critical mesenchymal to epithelial cell transition that occurs during CDH lung development and morphogenesis. In the future, you can envision that the delivery of a novel drug, either maternally or directly into the amniotic cavity, that specifically targets one of these dysregulated pathways to alter CDH lung development towards a normal phenotype could be developed. Antioxidants have been the subject of investigation to induce fetal lung growth in CDH. Several antioxidant drugs have already been studied and include vitamin A, vitamin C, and N-acetylcysteine. One intriguing paper presented in this APSASode is the abstract presented by Dr. Gupta from Dr. Matt Harding's laboratory at UT Houston. Using a biomarker of tissue hypoxia in a fetal CDH rodent model, this study contributes to the mounting evidence in the literature that the CDH lung may indeed be hypoxic and inflamed in utero before a child is even born, and that the transcription factor, HIF, may be important in this process. The implications of this novel hypoxia paradigm in CDH lung development is that antioxidants may help to reverse some of the abnormal remodeling of the CDH lung and improve mitochondrial dysfunction. Again, in the future, you could envision the delivery of a novel anti-hypoxia drug directly into the amniotic cavity of the CDH fetus, such as high oxygen carrying capacity nanoparticles as they have proposed. Specific immunomodulators of lung development are also viable drug candidates. And so it is interesting to note, though, that a similar approach of targeting both hypoxia and inflammation of the lung is used in an exciting acute lung injury abstract presented in this APSASode by Dr. Nimiek from the University of Colorado. The fascinating abstract presented in this session by Dr. Yu from Dr. Mark Puder's group at Boston Children's Hospital really puts a different spin on pharmacotherapy for CDH lung growth, and that there is now some compelling evidence that to suggest that our current drug therapies may actually be deleterious to early postnatal lung growth. In this case, Dr. Yu presents interesting data that heparin, which of course is used in copious amounts to anticoagulate our ECMO circuits in our most severe cases of CDH, actually impairs compensatory lung growth in a postnatal pneumonectomy model. These results are very intriguing, given that the mortality rate of CDH on ECMO still hovers around 50%. And there are questions, of course, regarding the mechanism by which heparin might impair lung growth. Since there is evidence that heparin may disrupt angiogenic signaling, this has obvious implications on whether anticoagulation alternatives, and in particular the direct thrombin inhibitor bivalirudin, may have more favorable effects on neonatal lung growth. The second major experimental approach to affect fetal CDH lung growth involves the use of stem cells or its derivatives, including extracellular vesicles, or EVs, which are interesting nanoparticles that are naturally released by cells that carry a bioactive cargo of proteins, nucleic acids, and lipids. Thanks to Grosfeld Scholar funding that I received from the APSA Foundation exactly 10 years ago this month, this has been of particular interest in my laboratory, and we've been fortunate to publish several papers in this area. In recent years, this work in this CDH research space has really been advanced by the Toronto group and other laboratories such as Dario Fauza's group at Boston Children's, with the most likely mechanism of stem cell-based lung growth being paracrine in nature. In one abstract presented in this APSASode, Dr. Collage from the Zani group uses EVs derived from human amniotic fluid stem cells in a novel ex vivo human fetal lung culture system where lung hypoplasia is induced using a RAC1 inhibitor, which has been previously shown to block a key pulmonary morphogen, FGF10. Critically, he was able to show that both branching morphogenesis and SOX9, which is a marker of distal lung epithelial progenitors, can rescue the lung phenotype following delivery of human EVs in culture for 48 hours. Although it remains to be seen whether this pilot culture system using RAC1 inhibition is a reliable surrogate model for the actual CDH lung, these findings are very exciting and suggest that a cell-free approach may be an effective strategy to promote fetal CDH lung growth. So in summary, I hope that I have convinced you that basic and translational scientific research in CDH remains vibrant within the APSA organization, largely because CDH continues to be such a substantial, frustrating, and vexing problem in our daily work as surgeons. Continued advancement in our field will require ongoing work of certain scientists. If not, who's going to do it? I highly doubt that our colleagues in MFM, neonatology, pediatric pulmonary, and PhD-based basic scientists have the interest, bandwidth, and perspective that we do as pediatric surgeons to advance the basic science of CDH. Ongoing refinements in operative technique, ECMO, and fetoscopy will of course be essential, but I think it is also clear that they aren't the magic bullets that they have been touted to be. And so I believe that a combination approach using novel drugs and/or stem cells based on science is much more likely to produce substantial therapeutic benefits for those at the severe end of the CDH spectrum. I would like to congratulate all of the APSA abstract presenters during this APSASode for their amazing work. Thank you very much for your attention. My contact information is here on the slide. Happy to answer any questions that you may have offline. Thank you.
And now we move to the second session, which is on tumors. I would like to ask Dr. Modupeola Diaholu to present paper on high RAS expression is associated with poor neuroblastoma patient survival.
Hi, my name is Modupeola Diallo, and I will be presenting our work titled High RAS Expression is Associated with Poor Neuroblastoma Patient Survival and Required for Tumor Formation. There are no disclosures. Neuroblastoma is the most common pediatric extracranial malignancy, resulting in hundreds of new cases yearly. Treatment requires a multimodal approach, and remission can be especially difficult with high-risk features or poor prognostic indicators. Research is typically focused on MECAN amplification. However, this accounts for approximately 22% of tumors. The RAS-MAPK pathway has recently been found to contribute to neuroblastoma formation. Specifically, there's evidence that mutations in RAS genes, NRAS, HRAS, and KRAS, leads to activation of this pathway and establishment of neuroblastoma. Because of these findings in human tumor cells, we hypothesize that high RAS expression results in poor patient survival and RAS inhibition delays tumor formation. In order to test this hypothesis, we developed a RAS monobody NS1 that inhibits HRAS and KRAS mediated signaling by binding the allosteric lobe and preventing self-association and clustering, preventing RAS activation of downstream effectors. Since only 22% of MICN amplified neuroblastoma tumors have poor prognosis, we looked at MICN non-amplified tumors to find further therapeutic options. We identified subpopulations of neuroblastoma, which are MICN non-amplified, have MICN low expression, and have HRAS expression. When comparing patients with neuroblastoma who have HRAS high expression to HRAS low, those with HRAS high tumors had statistically significant poorer overall survival. We used SKNFI cells because these cells were MICN low and HRAS high expressed. We stably infected this cell line with a lentivirus encoded with doxycycline-regulated NS1 expression construct that allowed for chemically regulated NS1 expression and RAS inhibition called SKNFI NS1. These cells were either treated with doxycycline or no doxycycline to determine the effects of RAS inhibition on cell proliferation and ERK-MAPK activity by Western blot analysis for PERK levels. In the Western blot on the left, the bottom two panels demonstrate total RAS input and NS1 expression in the cell lysate. NS1 expression decreased RAS GTP levels. The top panel demonstrates inhibition of RAS after exposure to doxycycline. In the next Western blot, the middle panel is the expression of ERK in the cell lysate. Phosphorylation of ERK requires RAS activation. The bottom panel confirms NS1 expression, and the top panel confirms that in the presence of doxycycline, NS1 inhibited phospho-ERK levels in SKNFI cells. In terms of cell proliferation, we saw that cells that were treated with doxycycline had a significantly decreased proliferation when compared to cells that had no exposure to doxycycline. This graph demonstrates the evidence of neuroblastoma tumor after cells were injected into the adrenal gland. Mice who did not receive dox water with no induction of NS1, therefore no RAS inhibition, began to develop adrenal tumors at 13 days post-injection, while those who did receive dox water developed tumors on day 30. By post-cell injection day 34, all non-dox treated animals had developed tumor, while only 60% of dox treated animals had evidence of tumor. In conclusion, NS1 can be used to help determine the role of RAS in neuroblastoma tumorigenesis by inhibiting HRAS and KRAS to decrease RAS activity. Inhibition of RAS delays tumor formation, suggesting that the RAS-MAPK pathway could be used as a target for therapy. Patients with high HRAS expression have poor overall survival. Thank you for your time. If anyone has any further questions, I've included our contact information here.
Thank you, Dr. Diallo. The discussant for this paper is Dr. Richard Goyer.
Well, hello, and thank you for joining us. My name is Richard Geyer. I'm on the APSA Research Committee and a science discussant for this abstract. So first of all, thank you, Dr. Diallo and Dr. Chu, for a really interesting presentation. As you note in your abstract and presentation, the driving oncogene in a significant fraction of neuroblastomas actually is unknown, leaving a lot of research still to be done to understand the biologic drivers of the great majority of these tumors. And I think the work you presented today was a really important first step, suggesting that RAS may have an important role to play in the biology of neuroblastoma. So if you don't mind, I'd just like to ask a couple questions that I hope you could address over the next couple minutes. And the first is that although RAS certainly is an oncogene that can drive tumorigenesis, we also know it's a critical signaling node during normal development and normal homeostatic signaling pathways. It seems like from the data in your abstract and your talk that your NS1 construct causes near total elimination of RAS signaling in the cell line you used. Do you think it's possible that this construct prevented tumor formation in your model, not because of RAS modulation in this particular tumor cell line, but rather because RAS was completely inhibited by the construct, rendering the cells non-viable? And as a sort of a follow-up to that, do you think that it would be important to examine the tumors that you grew in these mice and make sure that the tumors didn't emerge later because of the emergence of subclones that were not expressing the construct?
Thank you for your questions. So to start off, in regards to the decreased signaling, the RAS signaling in the SKNF cells, where the NS1 monobody is activated, the signal is specific to the SKNFI cells. So since the tumors do eventually form and grow, we believe that there's an alternative pathway or an escape pathway that the tumor cells use to continue the tumor growth program. This is also evidenced by the continued cell proliferation that we see in the doxycycline-activated SKNFI cells, which suggests that there continues to be some cell activity despite the inhibition of RAS. So the cells are viable. And with regards to future plans to evaluate the tumors, so like you mentioned, there are multiple avenues that we'd like to explore in the future. This really broadens up future experiments to find a specific therapy. The SKNFI tumors are not subclones where the NS1 is not expressed, because when we test the tumors that form after NS1 induction, those tumors do have a reduction of RAS. So we would like to actually evaluate cell lines similar to SKNFI that have increased RAS expression, and see if the effect that we demonstrated with the SKNFI cell lines remains true to those different cell lines. In addition, we currently have a recurrent tumor model, and we're looking to see if the inhibition of the RAS-MAPK pathway will actually decrease tumor recurrence. We also hope to study downstream molecular targets of the RAS-MAPK pathway to see if see how DOX induction can suppress the RAS pathway. And since there are many limited therapeutic options for patients with high-risk neuroblastoma, we may be able to identify a potential target that we can inhibit to decrease tumor formation.
Our next abstract in this session will be presented by Dr. Bounds from the University of Alabama at Birmingham. Her presentation is entitled Protein Phosphatase 2A Activation Decreases Tumor Origenicity in Neuroblastoma Patient-Derived Xenografts. Dr. Bounds.
Thank you for the opportunity to share our work today. Here are our disclosures. Despite advancements in medical therapies, the survival of patients with high-risk neuroblastoma remains dismal at less than 50%, with over half of these children suffering from disease recurrence. Therefore, it's imperative that we continue to investigate potential therapeutics for this patient population. Protein phosphatase 2A, or PP2A, is a phosphatase which has been found to be mutated or suppressed in cancer. And several PP2A activators have been shown to be effective at decreasing tumor burden. FTY720 is a PP2A activator that's been shown to cause growth arrest in several malignancies, and our lab has previously shown that FTY720 has decreased tumor growth in neuroblastoma. So we next investigated novel PP2A activators that were recently designed by a collaborator to have improved efficacy compared to FTY720 with less side effects, as the novel activators work by a different mechanism. So we focused on two of the novel activators, 792 and 1154, in 4 long-term neuroblastoma cell lines. And we found that treatment with 792 resulted in significantly decreased proliferation and viability, and 1154 had similar effects. We also evaluated the novel activators and their effects on motility, and we found that treatment with both 792 or 1154 resulted in significantly decreased migration, as well as significantly decreased invasion. Patient-derived xenografts are established by taking a patient tumor from the operating room, implanting it into an immunocompromised animal, and allowing the tumor to grow to the point where we harvest the cells and we're able to use them for experiments. PDXs have become a popular method to investigate therapies in the preclinical phase, as we can evaluate the effects of therapies in an environment that more closely resembles the human condition and compared to long-term lines. And because of our previous findings, we hypothesized that activation of PP2A using the novel activators will result in decreased survival, proliferation, and stemness in neuroblastoma PDXs. So we found that treatment with 792 resulted in decreased proliferation and viability in 3 neuroblastoma PDXs that were previously established at our institution. 1154 had similar effects. We examined migration using modified Boyden chambers, and this is a representative picture of untreated cells that were able to migrate through the chamber membrane. And compared to control cells, there was a significantly decreased ability to migrate following treatment with any drug in the COA129 cells. We also assessed invasion using the same assay, but lined the inside of the chamber with matrigel. And this is a representative picture of the untreated cells that were able to invade through the matrigel. And compared to untreated cells, there was significantly decreased invasion following treatment. Stem cell-like cancer cells are a subset of cancer cells that have the capacity for self-renewal and are thought to play a key role in neuroblastoma resistance to therapy, which allows for disease relapse. Stem cell-like cancer cells are identified by their ability to form spheres, so we use extreme limiting dilution assays to assess tumor sphere formation. And here's a representative image of what tumor spheres look like. This is a graph, is an example of the results that we get from the online analysis software that we use. So a horizontal line represents a higher number of wells that did not form spheres, so the cells are less stem-like, whereas a vertical line means that there are a higher number of wells with spheres, suggesting more stemness. The untreated COA 129 cells, represented by the more vertical solid black line, had an increased ability to form spheres compared to the cells that were treated with 792, as shown by the gray line, or LEM54, shown by the dotted black line. In conclusion, PP2A is a known tumor suppressor and is downregulated in numerous cancers. Our lab has previously shown that 792 or LEM54 treatment resulted in decreased viability, proliferation, and motility in long-term neuroblastoma cell lines. And here we demonstrate that these novel activators effectively decrease the malignant phenotype in neuroblastoma PDXs. So these findings support the continued investigation of these novel compounds in order to advance them into a clinical arena in order to serve a patient population that's in dire need for innovative therapies to effectively treat their disease. So I'd like to thank my mentor, Dr. Elizabeth Byerly, in the Byerly Lab at the UAB Department of Surgery and Division of Pediatric Surgery, are a collaborator in funding in APSA, for the opportunity to share our work today. Thank you.
Thank you, Dr. Bounds. The invited discussant for this paper is Dr. Bill Chu from Stanford University and the Lucille Packard Children's Hospital.
So thank you very much, Dr. Bounds, for this very interesting presentation. I have the following questions. Patient-derived xenograft cells generally do not grow well in 2D plastic plate. Can you share some insights in how you culture these cells?
Yeah,
Also,
yes,
can you, so go ahead.
I'm sorry. Yeah, thank you for your questions. Yes, I agree. And we did not use 2D cultures to pass these cells. So we took cells directly from the mouse and dissociated them into single cell suspension and then treated them and used them for the experiments. And then once dissociated, these cells can survive about 10 days in 2D culture. And none of the studies that presented here lasted longer than a week.
I see. So you generally use the mouse as basically a culturing medium and then use those to produce more cells for your experiment.
Yes, sir. That's how we propagate the cells. Yes, sir.
Great. And then can you provide some additional information on the characteristics of these PDX cells? Are they MYC amplified? Are they from primary recurrent tumors or established from metastasis? Or were those patients previously treated with chemotherapy?
Yeah, so these PDXs are from male and female patients. So the COA3 and the COA6 are from both high-risk MYC amplified primary adrenal masses that were established prior to any treatment or chemotherapy. And then the COA 129 is from an MS primary adrenal tumor, MYC non-amplified, but it was previously treated.
Did you find that it was, were you involved in establishing these cells before? Were they difficult to establish? Because generally they can be quite challenging.
Yeah, yes, sir. They, for my convenience, I guess, they were previously established prior to me joining the lab. So I got the benefit of being able to utilize these cells for experiments.
Great. And as you mentioned, PDX cells are thought to be more closely, that can more closely recapitulate the original tumor in terms of gene expression and tumor microenvironment. So did you create xenografts in mice using these cells? If you did, were you able to test the effect of PP2A on these xenografts in vivo?
So we do create xenografts in mice. So like I mentioned previously, we take a piece of tumor from the tumor that we harvest and implant it into another mouse. And so that's how our PDX lines are propagated. And unfortunately, these tumors grow slowly and at vastly different growth rates. So it makes any sort of in vivo experiment very difficult.
And then were you able to perform a titration study with decreasing concentration of PP2A to find the minimal concentration to be effective in these PDX cells?
Yes, sir. So we did perform titration studies. Our initial investigations looked at viability at increasing concentrations of these PP2A activators in order to establish an LD50. And so then this value was utilized in subsequent studies as a starting point for us to choose drugs for future investigations.
And lastly, as you know, PP2A can be upregulated or downregulated in different cancers depending on the context. Can you discuss a little bit how PP2A signaling can play a role in neuroblastoma?
Yeah, so yes, sir. We think that the suppression of PP2A is occurring in neuroblastoma, since we have previously shown that activating PP2A in 4 long-term passage neuroblastoma cell lines resulted in decreased viability, proliferation, motility. And in addition, treatment with these PP2A compounds, 792 or 1154, decreased the expression of 2 oncogenic proteins, MYC-N and beta-catenin. So therefore, we believe that PP2A is downregulated in neuroblastoma, and that activating this phosphatase will lead to a more aggressive or a less aggressive phenotype.
Great, great. Well, thank you. That was great and great presentation, and I look forward to more great work from you and the Byerly Lab in the future. So thank you.
Yeah, yes, sir. Thank you again for your questions.
The next paper will be given by Raud Marayati on chemokine receptor CXCR4 mediates the metastatic phenotype of hepatoblastoma cells.
I would like to thank APSA for allowing us the opportunity to present our work today. We have no disclosures. Patients presenting with metastatic hepatoblastoma have limited treatment options and survival rates as low as 25%. We have previously seen that overexpression of PIM3 kinase promotes the metastatic phenotype of hepatoblastoma cells. When hepatoblastoma cells, either overexpressing PIM3 or transfected with an empty vector control, were injected in tail veins of thymic nude mice, the mice were monitored for in vivo bioluminescence to detect lung metastases, and their lungs harvested, sectioned, and stained with H&E. We found that PIM3 overexpression resulted in an increased metastatic burden compared to control hepatoblastoma cells. We also found that overexpression of PIM3 kinase led to increased phosphorylation of CXCR4 when evaluated using Western blotting. Chemokine receptor CXCR4 is a key regulator of cancer metastases and has been implicated in migration and invasion of various cancer types. So we asked the question, does PIM3 act through CXCR4 to promote hepatoblastoma metastases? We hypothesized that CXCR4 mediates the PIM3-induced pro-metastatic phenotype of hepatoblastoma cells, and that CXCR4 blockade would inhibit the migration and invasion of PIM3 overexpressing cells. To test this, we used PIM3 overexpression cells and empty vector controls, treated both with increasing concentrations of AMD3100 for 24 hours, and used flow cytometry and an anti-CXCR4 PE antibody that competes with AMD3100 in binding to the receptor. So we're able to evaluate receptor blockade by looking at the CXCR4 signal, and we also evaluated the metastatic phenotype by looking at migration and invasion of these cells. We first saw that CXCR4 cell surface expression was greater in the PIM3 overexpression cells compared to the empty vector hepatoblastoma cells. This is quantified in this line graph. When we treated with AMD3100, we saw a decrease in the percentage of cells labeled with the anti-CXCR4 antibody in both the empty vector and PIM3 overexpression cells, indicating successful blockade of the CXCR4 receptor. On the left are representative histograms showing the decrease in CXCR4 expression signal as shown by the shift of the curve to the left following AMD3100 treatment. We also found that PIM3 overexpression cells exhibited enhanced migration and invasion at baseline compared to empty vector control cells, confirming a more invasive phenotype. AMD3100 treatment of both cell lines decreased migration and invasion in a concentration-dependent manner. Finally, there was no significant difference in migration and invasion of PIM3 overexpression cells treated with AMD3100 compared to empty vector cells treated with AMD3100, suggesting that CXCR4 blockade is able to abrogate the increase in the metastatic phenotype seen with PIM3 overexpression. In conclusion, PIM3 upregulated the phosphorylation and cell surface expression of CXCR4, which mediated the PIM3-induced migration and invasion of hepatoblastoma cells. Our findings suggest that CXCR4 may prove to be a plausible target for therapeutic intervention in metastatic hepatoblastoma. I would like to thank my mentor, Dr. Byerly, and members of the Byerly Lab, our collaborators and funding sources. My contact info is on the top right corner of this slide. Please feel free to reach out with any questions. Thank you.
Thank you, Dr. Marayati. The discussant for this paper is Dr. Reto Berschinger.
Dr. Mariatti, thank you very much for your excellent presentation on chemokine receptor CXCR4 that mediates PIM3-induced metastatic phenotype of hepatoblastoma cells. I really enjoyed your presentation and mechanistic approach, hopefully for future treatment in hepatoblastoma. I have a few questions. And so my first question is, when you treated your cells with the AMD 3100, did it affect all cell survival, or just the migration and invasion of your cells?
Yeah, thank you for your question. We evaluated both cell lines viability with increasing concentrations of AMD 3100 for 24 hours, and there was no effect on viability at doses as high as 100 micromolar of AMD 3100. We see an effect on migration and invasion at doses as low as 10 micromolar of AMD 3100.
Okay, great, thank you. My second question is, did the inhibitor affect other cell surface markers involved in epithelial to mesenchymal transition, like E-cadherin or N-cadherin expression? And what would the mechanism be?
Yeah, so we haven't looked at these markers specifically, but that's a great suggestion. Thank you. AMD 3100 has been shown to promote E-cadherin levels while inhibiting vimentin and N-cadherin levels. And it's also been shown to inhibit cell invasion and lung metastases through blockade of CXCR4 signaling pathway. This is specifically in prostate cancer. So that would be something interesting to look at in our cells.
Great, thank you. My third question is, do you know if PIM3 is expressed at different levels on various histologies or stages of hepatoblastoma? Higher pretext, does higher pretext tumors do they have more PIM3 expression or less? And how would it affect treatment in the future?
Yeah, so this is an area of great interest to our laboratory. So there is, unfortunately, a very small number of large publicly available databases of hepatoblastoma, the ones that are annotated with various histology or pretext risk groups. When we utilize the IKEDA database, for example, to evaluate PIM3 gene expression within 53 hepatoblastoma tumors using microarray data, what we found is that PIM3 gene expression was significantly higher in the 21 patients with recurrent or progressive disease compared to those with event-free, with like no event or event-free survival. Those were 32 patients. So these findings suggested that PIM3 plays a role in not only hepatoblastoma tumorigenesis, but also progression and disease relapse.
Excellent. And my last question is, AMD 3100 a molecule that you can use or that you have used in vivo, and how ubiquitous is CXCR4 in the mammalian organism to potentially predict some side effects of that inhibitor?
Yeah, so for the first part of your question, so we're currently performing in vivo studies to evaluate the effect of AMD 3100 on the formation of lung metastases in mice using tail vein assays. AMD 3100 is tolerated at 5 milligram per kilogram in the thymic nude mice that we use for 5 days a week for at least 4 weeks. AMD 3100 or Plerixafor is actually FDA approved and used in the clinic for the mobilization of hematopoietic progenitor cells for autologous transplantation in combination with G-CSF in patients with non-Hodgkin's lymphoma and multiple myeloma. For the second part, so ubiquitous expression of CXCR4 has been detected in a variety of normal tissues such as the bone marrow, lymph nodes, liver, lung, brain, and heart. So as you would expect, some of the serious side effects reported with AMD 3100 include a temporary increase in white blood cell counts, abnormally low platelet clot, abnormal heart rhythm, and low blood pressure. There's at least 9 other CXCR4 antagonists that are currently in phase 1 and 2 clinical trials. So this is all very exciting for a faster translation into the clinical setting, with CXCR4 being a plausible target, as we've showed in this study for therapeutic intervention in patients with metastatic hepatoblastoma.
Great. Thank you very much for your excellent answers, and good luck for your future experiments. Thank you.
Thank you.
The next paper will be given by Colin Quinn. And the paper is on the oncolytic herpes simplex virus effectively targets and kills neural crest patient-derived xenografts.
Thank you so much for giving us the opportunity to present our work today. We have nothing to disclose. Pediatric cancer is a leading cause of death by disease in children, with over 15% of the cases being attributed to neuroblastoma. The scan on your right is an example of neuroblastoma with a liver metastases. Unfortunately for neuroblastoma, current therapeutics are toxic and involve lifelong side effects. Immunotherapy, though, is an innovative approach to overcome these deficits. However, for neuroblastoma, there are currently a limited number of available clinical trials. This is partly due to the fact that it is difficult to study immunotherapy against neuroblastoma in a preclinical setting. One promising immunotherapy, though, is oncolytic viruses. Oncolytic viral therapy has shown successful in both solid tumors and is a novel area of investigation. Our lab uses M002, an oncolytic herpes simplex virus. This virus works by binding to receptors on neuroblastoma tumor cells, entering the tumor cells, replicating itself, then proceeding through lytic cycle. When it does this, it kills the neuroblastoma tumor cells, as well as releasing its progeny to go infect other tumor cells. And additionally, this virus is genetically engineered to produce IL-12. This IL-12 that will also get released helps stimulate an immune response against what is normally an immunologically cold tumor. Furthermore, our lab uses patient-derived xenografts as they can more accurately recapitulate the tumor profile and predict treatment response. Here in this investigation, we look at 2 high-risk neuroblastoma PDXs and MS neuroblastoma PDXs. And for the sake of this study, we also included another neurocrest-derived tumor, a pediatric rare high-grade neuroendocrine tumor. Initially, we want to assess whether the virus can even enter the tumor cells. And we do this by assessing expression of viral entry-mediated receptors. The 4 receptors we look at are CD111, CD112, syndecan, and HVEM. We can clearly see that in all 4 PDXs, they express each of these receptors. So now that we know that the virus can enter, we want to see if whether it is actually capable of replicating. Over a 24-hour period using a single-step assay, we assess whether or not the virus can actively produce enough virus. And we see that in each of the PDXs, it significantly produces a high amount of viral load measured by plaque-forming units per cell. We then assess how the virus replicates over time. And we can see that in most of the PDXs, the replication rate actually increases with M002 over a 48-hour period. Furthermore, we want to see how well the virus can produce IL-12 in each of the PDXs. This is not only a measure of how well the virus is replicating within the tumor, but it also helps us predict a potential immune response to the tumor. We can see that in most of the PDXs, we are able to generate IL-12 in each of them. Lastly, we then assess the viability of each of the PDX tumor cells following M002 infection. And we can clearly see that with increasing doses of viral infection, we find that there is a decrease in viability of tumor cells. So in summary, we were able to show that each of the PDXs express viral entry-mediated receptors. The M002 is subsequently able to infect and replicate within the PDXs, produce IL-12, and have cytotoxic effects against the PDX cells. So in conclusion, we were able to show that there was OHSV cytolysis in each of the neurocrest-derived PDXs. We also show that there was cytokine production, albeit both of these were tumor-dependent. These findings help support further investigation of using a virus like M002 with the goal of advancing this therapy to a clinical trial. I'd like to thank my amazing mentor, Dr. Elizabeth Byerly, the awesome Byerly Lab team, our funding sources, the UAB MSTP program, and everyone who made this project possible. Thank you.
Thank you, Mr. Quinn. The invited discussant for this paper is Dr. Tom Jaksic from Boston Children's Hospital and Harvard Medical School.
Colin, congratulations on a very clear presentation exploring the potential use of the genetically modified oncolytic herpes simplex virus M002 in treating high-risk neuroblastoma. Genetically modified oncolytic herpes simplex virus therapies have evolved over the past 30 years. And they have been used in various human trials with apparent safety and some efficacy. So your use of them in high-risk neuroblastoma is of great interest. I have 3 questions for you. Firstly, M002 did demonstrate cytotoxicity with respect to your 2 high-risk neuroblastoma tumor patient-derived xenografts. However, a significant proportion of cells appear to remain potentially viable. Why do you think this happened, and what implications may this have for the eventual clinical use of oncolytic herpes simplex therapies in neuroblastoma? Secondly, oncolytic HSV administration has been shown to be safe in at least one phase 1 trial of pediatric extracranial malignancies. Nonetheless, concerns always arise about off-target deleterious effects that can result from live viruses. How stable are the genetically engineered modifications that make oncolytic HSV tumor specific, and are there options to quell an untoward response to HSV therapy? And lastly, what are the next steps in your work?
Yeah, well, thank you very much for the questions. I appreciate them. So to address the first one regarding, the cytotoxic effects of the virus. So we were using it at a dose of 1 PFU per cell. And in this case, the studies were done in an in vitro setting. So we for sure could increase the viral dose to increase the number of cells we have dead. However, I think that the bigger component is that we're missing a huge piece that makes the virus effective, which is the immune system. So in an in vivo setting, when we're studying the virus, the part of the reason it's so successful is that it creates this debris field. And especially for tumors like neuroblastoma that are traditionally immunologically cold and aren't necessarily immunoreactive, the virus helps stimulate an immune response to the tumor and supplements the killing of the tumor cells in that setting. So in our in vitro studies, we use a little bit of a lower dose to allow us to do some of the other studies that we had done so in the presentation. Then to address your second question regarding the stability of the gamma 34.5 deletion, they've shown over time that this virus, and especially in adult trials, that it stays consistent throughout the patient. And there's not necessarily been seen any effects from it no longer being a neurovirulent over time. And then importantly too, which makes this virus beneficial, is that we're able to decrease its replication because it is still sensitive to acyclovir. So if a patient, starts getting horrible flu-like symptoms, which some of these patients will receive if they do get this clinical trial, we can give acyclovir to decrease any potential off-target effects from this viral infection. So then lastly, and conclusively, that transitions nice into kind of where I see this going is, importantly, we're looking for, funding opportunities to take this virus to a clinical trial setting for kids with neuroblastoma. And then for the bench side of research, I'm particularly interested in looking at that immune response, and in particular, how can we optimize specifically natural killer cell response to neuroblastoma that's been infected by M002.
Thank you, Colin.
Thank you.
The next paper will be given by Rachel Clark on the induction of SHMT2 promoting tumorogenesis in high-risk neuroblastoma.
Hello, and thank you for this opportunity to present our work entitled Induction of SHMT2 Promotes Tumorogenesis in High-Risk Neuroblastoma. We have nothing to disclose. Neuroblastoma is the most common extracranial pediatric solid tumor, accounting for approximately 15% of pediatric cancer deaths. MYC is a common deregulated gene seen in high-risk neuroblastoma. SHMT2 is an important mitochondrial enzyme that converts serine to glycine. It is upregulated in several cancers and is associated with prognosis and tumor aggressiveness. SHMT2 is regulated by AKT via increased glycine in hepatocytes, and AKT is an important regulator of metastatic potential in neuroblastoma. We have previously shown that SHMT2 is associated with MYC amplification, and that SHMT2 silencing regulates NMYC at the post-transcriptional level via decreased activation of AKT2. However, the functional role of SHMT2 in neuroblastoma tumor behavior remains unknown. In order to further evaluate the role of SHMT2 in neuroblastoma, 2 human neuroblastoma cell lines were examined. SHMT2 overexpression and silencing were performed using transfection of shRNA and an overexpression plasmid. Functional assays were performed, including cellular proliferation, colony counts, and cell migration. In order to assess the role of SHMT2 on cellular proliferation, CCK8 assays were performed at 24, 48, and 72 hours. As you can see here, SHMT2 silencing decreased cellular proliferation in both cell lines at 48 hours compared to control. And SHMT2 overexpression also increased cellular proliferation in both cell lines at 72 hours. In order to assess colony formation, the neuroblastoma cells were plated at 500 and 1,000 cells per well in a 6-well dish for 7 days. Colony formation was then assessed and the number of colonies were counted. As you can see on the left, SHMT2 silencing had significantly decreased colony formation compared to control. On the right, you can also see that SHMT2 overexpression had a significant increased colony formation compared to control. In order to assess cell migration, a wound healing or scratch test assay was performed. Cells were plated to 100% complutency, and then a scratch or a wound was created using a pipette tip at approximately 500 micrometers. Photographs were then taken using microscopy at 0, 24, and 48 hours after wound creation. On the left, you just see pictorial images of the wounds at 0, 24, 48 hours. And then on the right is the average wound gap at 0, 24, and 48 hours as well. So you can see here, compared to control, the SHMT2 silencing had decreased wound healing capacity or cellular migration at 24 and 48 hours compared to control. And the overexpression cell line had marked increase in cellular proliferation and wound healing capacity at 24, and at 48 hours had almost completely closed the wound. In conclusion, SHMT2 plays an important role in neuroblastoma tumorigenesis by contributing to cell growth, migration, and colony formation in vitro. Therefore, SHMT2 may serve as a potential therapeutic target for high-risk neuroblastoma. Thank you.
Thank you, Dr. Clark. The discussant for this paper is Dr. Ankush Gosain.
All right. Thank you very much, Dr. Clark. An excellent presentation, compelling data, and very nicely presented. I would expect nothing else from the Chung Lab. I have some questions for you about the work, and I'm going to start kind of high level, get down into granular details, and then go back to high level, if that's okay with you. First, I'm intrigued by the target or the focus of your work, SHMT2. And so what other effects does SHMT2 have in the body? Is it only really involved in serine glycine metabolism? And is that a critical function of the host? And therefore, is it something that's potentially druggable? So that's kind of the first one. The second is kind of now getting into nitty gritty. So what degree of silencing of SHMT2 and degree of overexpression were you able to achieve in each of the cell lines? And then do you have any data on the downstream signaling pathways in the setting of those silencing or overexpression experiments, such as PI3 kinase or AKT that you alluded to in your introduction? And then the next is, what are your plans for testing this in vivo? And what model systems are you planning to use and why? And then finally zooming back out to high level, where or when in the kind of sequence of therapies for high-risk neuroblastoma that are currently in place would you envision incorporating SHMT2 inhibition? So again, thank you for that really nice presentation.
Thank you. Let me just share my screen. I have a couple slides. So let's see. For the first question, so SHMT2, I didn't talk about it here, but it actually plays a role in hepatogenesis after hepatocyte injury. And it's also been shown to play an important role in neuron regeneration and ischemia after stroke. So it's basically involved in the body's recovery from damage, and particularly in areas of ischemia. It's also, SHMT2 has been shown to be related to HIF HIF1 alpha, the hypoxia-inducible factor. So that makes sense as well. So silencing it, while in theory would kind of be impractical because it could cause, complete cell shutdown and death, it really seems, just in the experiments I've seen and what I've read, to target the cells that are at risk in hypoxia. So, for instance, this cells that are able to overcome hypoxia and survive despite lack of resources have increased Schmidt. So that helps them overcome the nutrient depletion. So hopefully it would be targeting sort of the cancer cells that have that increased adaptability.
Yeah.
And then as far as, so the degree of SHMIT2 silencing, this is my PCR data. The AS cell line is here in the BE2C. You can see this is the SHMIT2 silencing, and then the blue to yellow would be the overexpression. So I just kind of broke them down into the raw numbers of the expression and how much it increased. So in the AS cell line, I got about a 1.3 time decrease in SHMIT2, and then overexpression was about 1.2. In BE2C, there was a 1.6 decrease, which was sort of expected to me because BE2C had more SHMIT2 expression at baseline. And then the overexpression was about the same in the AS and the BE2C, so 1.3 fold increase.
Okay.
And this was actually very similar in the siRNA silencing. So with the transient and the permanent knockdown, it was similar. And then, so this data, this is actually, they're from the transient knockdown data that I have. And you can see the AKT2, I don't know how well it's showing up on your screen, but with the SHMIT2 silencing, the protein expression went down, and the mRNA expression went down as well.
Yeah.
Let's see. And then your next question was about, sorry.
Your planned steps for in vivo testing.
Right. So hopefully the next, so in terms of like the big goal in vivo, ideally it'd be to do like a PDX model or a xenograft study where take the SHMIT2 silencing and the overexpression cells and inject them into the flanks of mice and measure the tumor growth, if any, and then hopefully be able to use that model to trial like SHMIT2 inhibitors, which some studies have found. There's none like pharmacologically available, but the idea would be to, if I can grow the tumor in vivo, then use that to find SHMIT2 inhibitors that work and test and see like how practical it is. And then sort of before that, another pathway I'm heading down is having to do with mitochondrial function. Our lab also studies GRPR, gastrin-releasing peptide, which is increase in high-risk neuroblastoma. And it has to do with the sort of the same pathway, PI3K, AKT. And we actually found that when you silence GRPR, there's no SHMIT to it, went away completely. And when we were looking at the mitochondrial function and stress in the GRPR silencing, they had significantly decreased respiration. So another step we're going to look at is with the SHMIT2 silencing and overexpression cells. Is it truly affecting mitochondrial function as we expect, and is it related truly to this GRPR pathway, or is this just some random finding that we found on a Western blot and got excited about? So that's our next sort of step. And then I'm also going to do some studies on metastasis. We have a metastatic cell line, LM2, that I'm working on. I did preliminary studies and found there's increased SHMIT2 expression in the LM2 cell line. So hopefully going to do some more studies on that and see if SHMIT2 silencing affects the LM function. And so that'll kind of help contribute to our in vivo studies as well in the animals once we get that running. And then let's see where I envision SHMIT2 inhibitors sort of playing a role in the treatment of high-risk neuroblastoma. So along that same lines of metastasis, I kind of think that's the key to SHMIT2 is metastasis, in that the cells that are able to metastasize are able to survive in that harsh environment of the bloodstream versus, their comfy tumor environment. And so I think that the cells that have increased SHMT2 are able to metastasize more, and that's sort of what I'm seeing in the cells. And then we did a Kaplan-Meier analysis of it as well, and there's decreased survival with increased SHMT2 expression. So I think where the key population is going to be children with to prevent either metastatic neuroblastoma or relapse, or the children that have metastatic neuroblastoma. I think that'll be key. So I don't think it'll be a first-line therapy, but I imagine if it did come to fruition, it would probably target them along the same lines as the anti-GD2 antibodies, monoclonal antibody therapy on there is what I imagine.
Okay. Excellent. Well, thank you again. Beautiful work, and I look forward to watching it as it continues to evolve.
Thank you.
It is my distinct pleasure to invite now Dr. Harold Lovorn from Vanderbilt Children's Hospital and University to present a short talk at the end of this excellent session on tumors. Dr. Lovorn has extensive experience in clinical care and investigation in this field, and will give us an update and reference to the papers presented. Harold, please.
Hello, I'm Bo Lovorn, one of the pediatric surgery faculty at the Monroe Carroll Jr. Children's Hospital at Vanderbilt in Nashville, Tennessee. I also have the honor of serving on the research committee for the American Pediatric Surgical Association, and I am delighted to provide this perspective on embryonal tumor biology and histology and surgeon contribution to our understanding of these different disease processes and the quest for new drug targets. An embryonal tumor is essentially a malignant tumor arising from the rudiments of an embryonic organ or from immature postnatal tissue, which forms primitive structures characteristic of the part from which the tumor arises. The hallmark or sine qua non of an embryonal tumor is the small round blue cell, which has characteristically a high nuclear to cytosolic ratio, as this little caricature shows. These cells are typically hyperchromatic with very scant pink cytoplasm. The study of embryonal tumors really centers around this concept of stemness. How do progenitor cells become rogue and then escape normal pathways of epithelial transition, which again is a hallmark characteristic of embryonal tumors. And these pathways are very similar in the dedifferentiation events that take place in adult carcinomas with a transition from epithelial to mesenchymal phenotype. So what is it about maintaining stemness? Well, the observation was made quite some time ago that embryonal tumors indeed may undergo spontaneous differentiation, either autogenously or after initiation of some form of therapeutic stressor, such as chemotherapy, radiotherapy, or resection. I happen to really appreciate this slide that was shared to me by one of my pediatric pathology colleagues here at Vanderbilt, Hernan Correa, which shows the progression of neuroblastic type cells from highly undifferentiated, which are just classically small round blue cells with minimal cytoplasm. These tumors are classically stroma poor. And note the intermixed variants of neuroblastic tumors that have differentiated type neuropil production, but that neuropil production also seems to be characteristic of small round blue cells or having some neuroblastoma element, because as these tumors mature into ganglioneuroma, neuropil is lost and they become stroma rich. Similarly, for Wilms tumor, one can see, as shown in this left upper panel, an 18-week gestation human fetal kidney with the cortex comprised of these normal small round blue cell nephron progenitors, from which stream the epithelial structures that comprise the proximal nephron. Recall that the distal tubular elements arise from ureteric bud structures. Contrast the normal fetal context with a Wilms tumor, shown here in the right lower panel, that is a classic triphasic Wilms tumor having many of the same histologic characteristics, such as primitive tubules, stroma, and even glomeruli. Finally, for hepatoblastoma, one can appreciate a very similar progression from either undifferentiated to differentiated elements, and much of that prognosis depends on how well differentiated a tumor may be. This composite image shows staining for sided 1, which labels embryonal tumor cells in hepatoblastoma brown, and one can appreciate this progression from low sided 1 staining in completely well differentiated fetal forms of hepatoblastoma to mixed epithelial, having both fetal and embryonal elements, a higher power view of that showing the immunostain for sided 1 in the embryonal elements, all the way to these very primitive looking embryonal cells. So again, for all three embryonal tumors, a clue really sits with this progression or capacity to differentiate terminally, if you will. So keep that concept in mind. Well, the study of embryonal tumors really is the interface of two disciplines, developmental and cancer biology. Of course, one, the developmental biology process is tightly regulated, whereas the cancer biology processes are highly dysregulated, leading to disorganized architecture and obviously no physiologic function. The cellular processes for self-renewal and proliferation, migration, homing, differentiation, programmed cell death, and adherence, detachment, and invasion are very similar between the two biologic systems, but of course one is completely unregulated without checkpoint regulation. A better understanding of these pathways certainly should help lead to novel discoveries of cures for cancer and new drug targets, as well as potentially give clues for tissue regeneration. This slide may well be the most important I want to share with you today, and that centers around this concept of normal asymmetric cellular division of progenitor cells, and then abnormal symmetric cellular division of rogue or cancerous stem cells. Let's take first the asymmetric process in the normal maturation of an organ. A stem cell, when it divides, will spawn two daughter cells, one that is fated to differentiate into the normal organ, and another that maintains stemness so as that the population of stem cells does not prematurely burn out. How does this process take place and then ultimately convert to just pure differentiated differentiated population of cells that will form the mature organ with a timed, highly regulated loss of this progenitor population? Contrast that process with symmetric cellular division in the malignant state, where a cancer stem cell will spawn two daughter cells that maintain their stemness, have pro-survival mutations, and then either show no or incomplete differentiation, and certainly improper differentiation that leads to no functional tissue architecture. At the core of this analysis of cancer stem cells is this concept of conventional cancer therapy versus having a highly specific cancer stem cell therapy. Conventional therapy is quite good at eliminating more differentiated cancer elements. Often, or at least as the hypothesis goes, the cancer stem cell will lay dormant for a period of time until that stressor from the chemotherapy or other therapeutic interventions is released. The cancer stem cell then begins to divide, and while this is largely a symmetric cellular division, certainly some cells repopulate a more differentiated form, as I've shown you in neuroblastoma, Wilms, and hepatoblastomas. So development of cancer stem cell specific therapy is what ultimately will induce complete tumor regression and cancer cure. Let's take first neuroblastoma, which is the most common extracranial solid malignancy of childhood, accounts for about 800 cases annually in North America and 12% of all childhood cancer deaths. Fundamentally, the schemata histologic classification is shown in this slide, and suffice it to say that the interested reader will have to go review these papers. The data are replete, but suffice it to say the initial branch point is at how rich is the stromal composition of each tumor. The presence of nodules is very important in determining whether it is unfavorable or favorable histology. The mitosis karyorhexis index is also critical, as is age. Simply stated, and these data hold true today, that unfavorable histology portends a much more significantly worse prognosis than favorable histology. Another seminal landmark manuscript and contribution to our biologic understanding of neuroblastoma was published in the New England Journal in 1985, in which amplification of the MYC-N gene or oncogene was shown to increase with increasing stage, and it became much more frequent that amplification of this oncogene in MYC was present with more advanced stage disease. In this paper, they showed that increasing numbers of copies of NMYC also impacted negatively overall survival, so that if only one copy of NMYC gene was present, those patients had a much more improved survival than those that had numerous copies over 10. That held true for stage 2 and stage 4 tumors. Stage 3 showed a similar pattern, but there were not sufficient case numbers really to show statistical significance. But nevertheless, overall presence of NMYC amplification greater than 10 copies significantly negatively impacted 5-year survival, event-free survival. Ploidy also is another critical feature that comes into play when we think about biologic risk assessment with neuroblastoma, and that can be broken down by age. This first panel A is less than 1 year, second panel B is between 1 and 2 years, and then panel C is if the child is over 2 years. Suffice it to say that diploid tumors had much worse survival when the age was less than 2 years of age. However, that relationship did not hold true above 2 years of age. These are for MYC-N non-amplified specimens. Also, loss of heterozygosity at 1P and 11Q portend worse survival long-term after treatment, and these survival plots are for event-free in panels A, and then overall survival in panel B. Note in each scenario that loss of heterozygosity at 1P and 1Q negatively impacted survival. Probably everyone's favorite biologic tree, the INRG survival tree, really shows features of histology, which is shown here being favorable for risk assignment if mature and differentiating. Image-defined risk factors, if they're absent, then the major branch point is whether MYC-N amplification is present. If image-defined risk factors are present, again, the context of MYC-N amplification portends a higher risk, which is shown over here with very low risk in dark green, low risk in light green, intermediate in orange, and high risk in red. After the MYC-N branch point, if it is negative for amplification, then age is a significant risk factor. And for children being less than 18 months of age, They're going to generally have a pretty good prognosis, especially if loss of heterozygosity at 11q is not present. But if it is present, that poses intermediate risk. And then one can see that histology re-enters the branch point here as well. When metastases are present, certainly for the MS form, any presence of MYC-N amplification portends high-risk assignment. If negative, again, loss of heterozygosity is the main branch point determinant. If it's present, those children fall into the high-risk category. Age is also a factor for standard metastases, again, with the branch points being MYC-N presence, ploidy, and then age. So I would like to congratulate the 4 authors of the outstanding abstracts that we have reviewed today for APSASode. And I happen to find this graphic very revealing that this concept of asymmetric and symmetric cellular division have their regulation through NMYC, which is a pathway that was studied in a number of these abstracts today, along with the ALK pathway, AKT, etc. And so really the core crux of what I'm trying to present to you today is this concept of how do we interrupt this symmetric cellular division in these highly malignant contexts of cancer stem cells. Congratulations to these authors for their outstanding contributions. Well, Wilms tumor was not a subject of presentation today, but I do want to discuss the upcoming new protocol for Wilms tumor that will have at its core a biologic branch point. And essentially, the presence of loss of heterozygosity at 11p15 for stage 1 patients will be determined in adverse biology. Then copy number gain at 1q has entered the branch point, and loss of heterozygosity at 1p and 16q combined will remain as a branch point with adverse biology. LOH at 1p or 16q in the context of positive abdominal lymph nodes will also portend adverse biology. Anything else is considered standard biology, and one can appreciate the early branch point of biology. Similarly, the persistence of blastemal cells, again, think back on that concept of cancer stem cells, how they evade therapy. So if a child has received neoadjuvant therapy and has blastemal predominance, that too will be determined as a histologic poor prognostic or high risk feature after delayed nephrectomy. For hepatoblastoma, we have less biologic risk stratification, and I encourage the young surgeon and junior faculty to consider how we can better understand hepatoblastoma biology. As it stands now, the principal clinical factors are older age and lower production of AFP in the context of increased pretext staging. The branch point, again, will be mostly determined by clinical features such as the presence of distant metastases, older age, and AFP less than 100. I'm sorry, less than 100. As far as histology, pure fetal histology that is completely resected up front will be considered the most favorable or very low risk context. Those patients really should experience a 5-year event-free and overall survival approaching 100%. I found this article quite compelling as well, that mutations in hepatoblastoma are quite rare when compared to other malignancies of the liver. However, interestingly, canonical Wnt pathway signaling through beta-catenin is activated in over 2/3 of cases, mostly from in-frame deletions of beta-catenin. Mutations in the beta-catenin destruction complex also are present, albeit somewhat less frequently. Other genes and pathways altered is the transcription factor NFE2L2. And then there are some genomic alterations that perhaps may one day enter into biologic risk stratification. The molecular risk stratification from this second paper is really quite interesting, with low risk features on the left, intermediate risk on the right, and high risk and very high risk on the right. And what I want to draw your attention to is the highly statistically significant association of Wnt beta-catenin activation in the very high risk and high risk categories, along with activation of NFE2L2. Other features of clinical interest are, again, older age, as shown here. And when compared with impact on survival, the highest risk group of the molecular risk stratum 3 significantly impacted event-free survival in a negative way. Congratulations again to the authors that contributed the highly significant paper evaluating the chemokine receptor CXCR4 and how it mediates hepatoblastoma metastasis through PIM3, which may one day be a plausible target for therapeutic intervention. So in summary, I want to emphasize the surgical contributions to our understanding of the biologic processes of various embryonal tumors, and then also to underscore how both biology and histology now are playing a part in our risk stratification and therapeutic assignment. Thank you again for the opportunity to share these perspectives.
I would like to thank all the presenters and discussants, Dr. Kunisaki and Dr. Lovon, for the excellent presentations summarizing the respective fields of research. And I hope that everybody attending this session enjoyed the presentation and got new information important for their activities. Again, a gratitude to all the presenters and their respective research team. Thank you.
Hello, everyone. My name is Mary Fallett, and I'm pleased to be the chair of the APSA Foundation. I hope that you enjoyed this year's Jay and Margie Grosfeld Research Symposium. Please stay tuned in for a few more minutes to hear about the foundation and while I announce this year's scholarship winners. The foundation is grateful for all of its donors who make programs like this possible. In 1991, a small group of APSA members led by Dr. Al Wilkinson of Jacksonville discussed establishing a foundation to support the scientific investigation of our members in the field of children's surgery by providing an annual enrichment grant. In 1995, after achieving 501c3 status, the foundation was born and Dr. Dick Ellis, the sitting APSA president at the time, was the first chair. He was succeeded by Dr. Grosfeld in 1998, who faithfully served until his death in 2017. The return on investment for the scholars has been phenomenal, with 39 grants awarded and at least $66 million in grant funding to those who were recipients. Dr. Tom Crummell succeeded Dr. Grosfeld, and under his tutelage, the scholars were renamed in Dr. Grosfeld's honor. We also credit Jay and Margie Grosfeld with a lectureship in their name to honor the research of the APSA members, which is the symposium you just attended. Please save the date of October 27, 2021 to hear about the good work that our current scholars have just completed. This will take place at 7 p.m. Eastern Standard Time. At that time, we'll hear from Dr. Alejandro Garcia, Johns Hopkins Children's Center, on his project Improving Reperfusion Injury and Pediatric Cardiac Arrest using a porcine model of eCPR. We have 3 scholars from 2020 presenting, Dr. Allison Spear from the UT Health Science Center on her project defining the role of the enteric nervous system and epithelial barrier function in human intestinal organoids. We'll hear from Dr. Krista Grant from Penn State, Contactin-1, a potential biomarker and therapeutic target in high-risk neuroblastoma, And last, Dr. Emily Partridge from CHOP on the study of cerebral autoregulation and pumpless arteriovenous extracorporeal membrane oxygenation. And now I'm delighted to introduce our three scholars for 2021, who are Dr. Augusto Zani from the Hospital for Sick Children in Toronto for his project Amniotic Fluid Stem Cell Extracellular Vesicles as a Novel Therapy for Pulmonary Hypertension Secondary to Congenital Diaphragmatic Hernia. Dr. Hao Leah from Madison, the effects of cold atmospheric plasma on neuroblastoma tumor microenvironment, and Dr. Jiang Huan, the role of progenitor cells in the pathogenesis of intestinal strictures in Crohn's disease. Thank you again from the Foundation for tuning in. Please remember that our foundation is the philanthropic arm of the organization. APSA does not have the budget to sponsor events like this, and your inspirational giving allows the foundation to fund grants and educational projects that benefit the members and our profession. Please save the date of October 27 to hear about our scholars' work. Please tweet about us and have a great weekend.